So let's begin with my disclosure. Here's a picture of me from 45 years ago when I was first working in a neuroscience lab. And in that 45 years, I've had a very wonderful career, which I was a career scientist in 2 different VA hospitals. I've received millions of dollars of funding from these different federal organizations on my research on PTSD and Alzheimer's disease, including extensive funding from drug companies. But I'm not covering any of that research here. The work I'm covering today is entirely unfunded, and it's based actually on my own personal concerns about my health. And you can see here why I was concerned and why my physician was concerned. So this is going back to the 1990s. My triglycerides here is 771, hovering around 800. HDL abysmally low at 34. And so it was there for almost a decade. So I was at extremely high risk, because those of you who know, and of course cardiologists will look at this and be alarmed, you want your triglyceride HDL ratio to be 1 to 1, maybe no more than 2 to 1, and I'm more than 10 times that level. And you look here, the notes that my doctor has on my blood tests, repeatedly having me come in to warn me of my high risk of developing heart disease. In fact, you can see one, recommended meds, is the patient agreeable? And so I, in my ignorance, I knew a lot about the brain, but not much about heart disease or diet. I believed that I could beat this thing, and this was for almost a decade, with exercise and low-fat diet. And all that happened was that I got fat, and my triglycerides went even higher. Finally, 2007, my doctor sat me down. He says, it's been almost a decade. You're on the verge of having a heart attack. It's just what this ad said. I was overweight. I had a ridiculous triglyceride level. It was really time for me to go on medication. He pretty much demanded I go on a statin and other medication. And I finally realized it's time to put my background in biology to good use. I need to learn about triglycerides and understand what it is that's actually putting me at such high risk of developing heart disease. So I went to the literature. And this is one of the first papers that I found, carbohydrate intolerance. And so this is a case study of an individual whose triglycerides were very much like mine at about 800 on a low-fat diet. And so what they had here, and this individual went on a very high-fat, low-carb diet. I said, I was patting myself on the back because I'm eating bread without the butter. And so now, actually, it turns out it's the bread and potatoes and the sugar that I was eating. So I followed this. I dramatically reduced my triglycerides by going low carb, reduced my triglycerides 75%, raised my HDL 25%. So I improved my overall profile. But I then became sort of a lean mass hyperresponder. Here it is, that once my triglycerides went low enough that you could measure my LDL, turns out it was extremely high, okay, which now gave me another problem. So here, as you got in the cartoon, the doctor's saying everything is going right. You went on the low-carb Atkins diet, but now your LDL is high. So my LDL was sky high at the time. So I needed to further look into the literature and understand, okay, now that I've got my triglycerides lower, okay, what am I going to do about it? Okay, now I need to learn more about the literature. And so just to give you a little bit of background, and Dave has already covered the FH concerns. This was discovered in the first half of the 20th century, and we're going to talk primarily about heterozygous FH, in which people do live beyond childhood, but in general, these people are said to die young. And so you have people with impaired LDL binding to cholesterol. They have high cholesterol in their blood, high cholesterol in their arteries. As you can see here, it is a disorder of hypercholesterolemia. And because that LDL then goes into the plaque, chokes off the arteries, and therefore people generally get heart attacks when they're young, and they die young. And that's confirmed in more contemporary work, which Dave also showed you this slide. So you can see someone with FH, you can see, is going into this red area. So if you have FH and extremely high cholesterol, you go into the red area, and you therefore are going to die relatively young. You have a cardiovascular event young, and it's unlikely you'll be able to get past your 50s or 60s. Primary reason is that high cholesterol then seeps into your arteries, clogs your arteries, causes you to die relatively young. And this is why this paper urges people to go on a statin to lower their cholesterol. So I went into the literature, again, looking at this as a scientist. I developed hypotheses. They're very straightforward. there should be a high rate of cardiovascular death as well as all-cause mortality in people with FH, and reducing LDL pharmacologically should safely and effectively reduce mortality. Very simple, very straightforward. So I'm looking in the literature, and I found numerous papers showing the good health of people with FH and the great longevity. So here is one of the largest studies on people with FH, published in Medicine, over 1,000 people of different ages looking at their health, finding, in fact, surprisingly, they have great health and great longevity. And these authors are concluding that men and women have a normal lifespan with astronomically high cholesterol. They're living into their 7th and 8th decades. And there are numerous papers like this published in the middle of the 20th century. And we look at a more contemporary study that pretty much confirms this. So this is a very important study because you have genetically confirmed FH people, almost 5,000 people, and you're looking at lifespan. You're looking at their health. Now, if you look at the first 2 bars, so the first 4 decades of life, it is the case that people with FH do have more heart disease. They do have a tendency to die relatively young. And that is why the number 1.0, that's the rate of death in the general population in Norway for each age. So it is slightly higher, which indicates that a subset of people with FH do die at a relatively young age. But notice there is no asterisk there. So it is only a small percentage of the people with FH, which I will get to later as to why, but only a small percentage of people with FH actually die young. And it's not statistically different from the general population. But now as you look to the older ages, as people with FH are getting older, they are dying at a lower rate than the general population, beginning at age 60, which is when people are at the greatest risk of dying of a heart attack or stroke. And in fact, people at 70 years of age are dying at a much lower rate than the general population. They're dying at 40% lower rate than the general population. So if you're 70 years of age and you've got FH, you are healthier than the general population. In the next 10 years, you are less likely to die. And this is independent of any cholesterol treatment. And overall lifetime rate of death is no different from the general population. And the authors point this out, that in fact there's no difference for FH people at any age other than the fact that 70-year-olds die at a lower rate than the general population. And so let's look a little more detail. What are they dying of? Well, the people who have FH are dying at the same rate as the general population from cardiovascular disease. But they're dying at a dramatically lower rate from cancer and other non-cardiovascular diseases. So the people with FH are healthier than the general population. They're dying at a much lower rate of non-cardiovascular diseases and at the same rate as cardiovascular disease. Very surprising findings when you think that these people must get their cholesterol down in order to live longer. Now, it's not just the FH population. I've had the pleasure over the past 15 years to work with numerous clinicians, scientists, and we reviewed the entire literature on the non-FH population of elderly people, that's people over the age of 60, who have extremely high LDL cholesterol. And there wasn't a single study showing a higher rate of death in people with high LDL compared to low LDL, which is why we concluded this kind of work certainly should challenge the validity of the cholesterol hypothesis, that high cholesterol is choking off your arteries and causing you to have a premature death. Now, why is it that elderly people with high cholesterol are actually healthier than those with low cholesterol? And so here, the cardiologist may be concerned about high cholesterol, but the immunologist should be very happy about having high cholesterol, because most people are not aware that cholesterols, particularly lipoproteins, are a part of the immune system. And here are just a couple of papers reviewing this, in which it's stated, lipoproteins are important components of the immune system. It is a part of our innate immunity system. And there's extensive work in which you model this in animals. The conclusion is specifically endogenous LDL can protect against lethal effects of the toxins produced by bacteria. So LDL works with white blood cells to remove viruses and bacteria as well as to target cancer cells. So LDL is a part of the immune system. Having high LDL is healthy. Let me say that again. Having I know he's like, whoa, seriously? Having high LDL is healthy. So I'm not surprised that Dave Feldman's folks are so healthy and that they don't have any coronary calcium. So high LDL is healthy. So let's look at some studies, okay? And so here's a nice study. We just saw this. It's work of Karam, in which we're looking at coronary calcium in people with FH. And they showed two populations. We have a population here shown with the red line, which did not have any major coronary events. And we have a population in blue in which they had coronary events. And these people are on statins. And so you're looking at their LDL levels. And so if you just look at the LDL, it doesn't tell you the difference between the group that has heart disease and the group that doesn't. So you see their LDL levels for the two groups. And so in red, they have no coronary events, and in blue, they do. So the LDL does not tell you why one subgroup has heart disease and one doesn't. So the vast difference now is in their coronary calcium, which is consistent with what we've heard already. So the group that has the heart disease has significantly higher coronary calcium, over 200. The group that didn't have heart disease, and again, high levels of LDL, they have 0 coronary calcium. So what else might tell us about the difference between these two groups? Their fasting glucose. The group that had coronary events had significantly higher fasting glucose, which is in the prediabetes range. The FH group that did not have coronary events had low fasting glucose. So this is really important to realize. There are other factors that are far more important than LDL, and one of those is fasting glucose. Now, I've also had the pleasure to work with so many people who are clinician scientists and PhDs as well. So in this review we had in BMJ, we looked at dietary recommendations for people with FH, which are just atrocious. They are still recommending low-fat, low-cholesterol diet to people with FH. In this review, we covered insulin resistance as an important factor in producing coronary events in FH. So here is one study looking at coronary artery disease in people with FH. And if you look to the far right, the people that have 7 times as much coronary artery disease as your control population, these are people that have high fasting insulin and high waist size, overweight people. So insulin resistance, again, tells you about the likelihood that someone with FH will have a heart attack. This takes into LDL. LDL is removed from the equation. All these people have high LDL, but as you look now to the left, the people with FH with high LDL that have low fasting insulin and low waist size, their rate of coronary artery disease is no different from the non-FH population. Again, the critical factor is not LDL. It has to do with the metabolism, specifically insulin resistance and being overweight. So let's look at another study on people with FH because it serves as a good model to understand what happens with high LDL. So here is a contemporary study, genetically confirmed FH. And if you look at the left, and you have 2 bars, you have groups that are diagnosed with coronary heart disease and those that have no coronary heart disease. And we look at their lipids. Total cholesterol is astronomically high. These are people who are not on statins. Extremely high cholesterol, extremely high LDL. I have those lines in the arrow down. That is what's recommended for people, to have their total cholesterol below 200. LDL should be below 100. And these people have extremely high. LDL is over 250. And we have 2 groups in which there's no difference between those 2 lipids. There is a difference. The HDL tends to be lower in those with heart disease. Triglycerides are higher. But the most important thing right now to look at is no difference in their LDL. Where is there a difference? So there is a protein that is important for clotting called prothrombin. And there is a genetic form of prothrombin that puts people at greater risk of developing heart disease. So a subset of people with FH have this polymorphism. And so if you got the polymorphism that increases your risk of having heart disease, it doesn't matter whether you're actually FH or non-FH. This polymorphism increases your risk of excess clotting. And it is independent of LDL. Let's look at another study, which is quite convenient that this is published before the development of statins. So again, we are looking at people that have FH, but a subset have coronary heart disease and a subset don't. And when we look at the lipids, we see absolutely no difference between the two groups. Total cholesterol is sky high, over 300. Of course, there's no medication now effectively reducing their LDL. So their LDL is at about 250. No difference in HDL as well as triglycerides. And yet you have a population that has heart disease and a population that doesn't. So what is different between these two groups? Clotting factors. So the population that has heart disease has significantly more fibrinogen and factor VIII. These are two important proteins that are involved in clotting. So if you have more fibrinogen and factor VIII, you are more likely then to produce clots. For example, when you get stressed, or if you have high blood sugar, or you smoke, that triggers clotting. So clotting, again, is seen as a critical factor that increases risk for heart disease, and it is independent of your cholesterol. So people with FH do have more heart disease. So again, I'm pointing to clotting factors as being critical. In general, people with FH have more viscous blood. They have thicker blood. People who have more viscous blood have more heart disease. So this is a really nice study in which these people have taken the blood from people with FH and they have filtered out either fibrinogen or the lipoproteins, and they're looking at the viscosity. And when you filter out the fibrinogen from their blood, there's a dramatic and significant reduction in viscosity. Filtering out the lipoproteins, and specifically the triglycerides, tend to reduce that viscosity. So taking out the LDL has essentially no effect. And so that increased viscosity that you see in people with FH, that is because they, in general, have more fibrinogen. Okay, and that is increasing their risk for heart disease. There is more to FH than the cholesterol, that there is a subset of H that has extremely high clotting factors. And that has been largely ignored in the literature. So we reviewed this work. And whenever it is reported simultaneously, clotting factors and LDL, the clotting factors are far more significant, are clearly a better indicator of those subset of people that have FH that are the ones that have heart disease. And we published this a few years ago, that it is clear that the subset of people who suffer from premature cardiovascular disease are the ones that have coagulopathy, that is hyperactive clotting systems. It is independent of their cholesterol. And this is not just the FH population. So here's a study that's looking at fibrinogen and plasma viscosity. And so they're taking into account, they're measuring LDL. And they're saying beyond LDL and conventional risk factors, critical risk factors are fibrinogen and plasma viscosity. So the individuals in the general population that have increased fibrinogen and increased viscosity, these are the ones that are at greater risk of developing heart disease, and this is independent of all other risk factors for heart disease. So again, to emphasize that this is really well established in the literature, that fibrinogen, this is a protein that when it gets activated, turns into fibrin, which then triggers clotting in the blood. And understand, because I also study stress, when we get stressed, when we have high blood sugar, that activates the fibrinogen. You don't need to be wounded to make a clot. So this is why stress is associated with heart disease, because it triggers the clotting process. You literally have clots passing through your blood when you get stressed and when you get angry. That's the activation of fibrinogen. And so what you see here on the left, coronary heart disease and stroke on the right, it shows one of the best biomarkers of heart disease is fibrinogen, and it's independent of age from 40 years of age on. People with more fibrinogen have more heart disease and more stroke. So Dave already had mentioned ApoB and the particles, so it's nice that you've already covered a bit of that. And so LDL, of course, is packaged inside the particle. Calling the particle, whether it's ApoB is the protein or LDLP is the particle. So it's important to now go into some detail to understand how the LDL is packaged. And so you've got different kinds of particles. If you have a person that has very low triglycerides and very high HDL, and you've got a healthy metabolism, well, when that LDL, which previously had been packaged in the liver, ultimately becomes an LDL, that LDL either can be very large, which is called large and buoyant, or if there's a condition which is high triglycerides and low HDL, then the LDL is seen as what's called small, dense LDL because of the high triglycerides that are present. You can think small, dense LDL, small, damaged LDL. It is not a natural LDL that you will find in a healthy person. You see small, dense LDL predominate in a person that is unhealthy, that has metabolic syndrome, that has insulin resistance. So it's important to distinguish the two kinds of particles. I don't know why that happens. So let's look at people that have the small, dense versus high amount of small, dense versus small amount of small, dense particles. So here's a very nice paper in which you're looking at people either have very high small, dense LDL versus a low amount of small, dense LDL. And the people that have a high amount of small, dense LDL have extremely high triglycerides, over 200. If you've got a low amount of small, dense LDL, you see the very low triglycerides. And then when the people with the high amount of small, dense LDL now have much more metabolic syndrome. So over 70% of the people with high small, dense LDL are diagnosed with metabolic syndrome, and it's rare in people who have very low small, dense LDL. So it's important not just to talk about LDL cholesterol, but let's talk about the actual particles. So here we are actually looking at events based on people's particles. So you see here in red, the people that have a high percentage, a dominance of small, dense LDL, have more events over time. So you're looking over the course of years, those who have a high dominance of small, dense LDL have more events than those that have a very low incidence, a low rate of small, dense LDL. And so it is associated with coronary heart disease. And I really want to emphasize, small, dense LDL does not exist on its own. It is a part of a damaged metabolism. It is a part of insulin resistance. It's a part of metabolic syndrome. So this is just another indicator of poor health. But let's look at the large buoyant LDL. Large buoyant LDL, at worst, is benign. More importantly, is potentially a part of the immune system. It is healthy LDL particles. And there is no association of the large buoyant LDL. My audio. Okay. There is no association of the large buoyant LDL to coronary heart disease. So there's sort of a foolishness in talking about LDL-C when we really need to understand about the particles and how the particles, the individual LDL components, represent, illustrate your overall health. And so stroke as well. Stroke is very inconsistently related to LDL. And part of the reason is that LDL, total cholesterol is LDL, you see is not very well related to incidence of ischemic stroke. So here's a study of people who have stroke, and you have two groups, those who have the stroke as well as those who have not had stroke, and you see no difference in their total cholesterol or LDL-C. And again, LDL-C is just the total amount of cholesterol in all the different particles. But there is a difference then in their small, dense LDL. So the people that have more small, dense LDL have more ischemic strokes. And again, I want to emphasize, this is just an indicator of poor health. Okay? It's like having high blood pressure, high blood sugar, high small dense LDL. It is a biomarker of poor health. So think about this way. So LDL-C is simply a global marker. It is a hybrid marker. It contains the different components, such as small dense LDL and the large buoyant LDL. So when a person goes on a low-carb diet, they reduce their small dense LDL, and they can sometimes dramatically increase their large buoyant LDL, which may have many different effects on their total LDL cholesterol. LDL cholesterol could stay the same. It could go very high. But realize, if the large buoyant LDL increases, that could drive up total LDL cholesterol. But that increase in large buoyant LDL is not seen as something that's hazardous. Now, and we reviewed this literature a few years ago. I had the pleasure to work with a cardiologist, Blair O'Neill, and Jeff Volek, in which we reviewed the literature on low-carb diet. And if you look at the 2 points where there are arrows, and overall the biomarkers all go in the right direction. On the right, it's good that they go down, and you notice where it's SD-LDL on the right, the small dense LDL drops, and on the left you can see a substantial increase in the large buoyant LDL for people on low-carb diet. So the two are moving in the right direction, and LDL-C can go anywhere. Sometimes no change. Overall, on average, it goes up slightly. But again, it's irrelevant. Now, there is another component of LDL-C, just to show you how heterogeneous it is. And this is the lipoprotein A, or Lp(a), which Chopin Huggins, I think, has covered it so very nicely that this is really complicated. And this, in general, we're seeing this has to do with wound healing, and its relation to cardiovascular disease, frankly, is quite complicated. But there are numerous studies that shows that it is associated with heart disease. And so there's a very nice paper done by Samikis' group in which they were able to distinguish the Lp(a) component from the non-Lp(a) component in LDL-C. So they separated the two components. And this is the important finding. When you separate the Lp(a) from the rest of LDL-C, LDL-C is no longer associated with heart disease. It is only when the Lp(a) was in this measure that LDL-C was associated with heart disease. So you see how antiquated it is, how unscientific it is to even use LDL-C if you want to talk about heart disease, because it's a hybrid measure of multiple components. Each one has a different influence or no influence on the expression of heart disease. And now, of course, we come to the topic, which is, well, this all doesn't matter. And as Karam said earlier, statins work. We might as well have it. The adverse effects are minimal, and statins save lives. And people have said it doesn't even matter if they don't lower LDL because statins save lives, and they reduce heart attacks. And so here's an ad in which a Crestor ad. And for those of you who have seen my other talks, I've made fun of Lipitor before, and today for the first time I'm going to make fun of Crestor. So we've got this ad, and the doctor is so happy, you're lowering your cholesterol, and here this woman is just so overjoyed, and she's lowered her risk of having a heart attack by 54%. So let's look at this Crestor study. And here I've actually taken CME courses. I audit these courses to see what doctors are learning. And so this is a slide from a CME course showing how dramatic the benefit was for Crestor in the Jupiter study. And in fact, it was this effect that resulted in rapid FDA approval of Crestor for people, especially those with high inflammation. And here is a summary, and this is how it was presented in the paper, of the phenomenal benefits of Crestor for people with heart disease. Or actually, this is a primary prevention study. So this is even showing for healthy people, by lowering their cholesterol and inflammation, you dramatically reduce the incidence of heart disease. So you see there's a 44% overall reduction in events, a 54% reduction in myocardial infarction or heart attacks, 48% reduction in stroke, and also reduction in all-cause mortality. So these are the phenomenal effects, and it certainly indicates that if you're a practicing physician and you're prescribing this to your patients, it certainly looks like you're going to reduce the incidence of a heart attack in your patients by over half. Half of your patients are not going to have a heart attack. So let's actually look at that 54%. The reduction in heart attacks in patients. It certainly suggests that half of all your patients are not going to have a heart attack. So what I'm going to show you now is the percent of people in the Jupiter study that did not have a heart attack. Okay, and that's right there. And so there is a 54% risk reduction between these two. The percent of people that did not have a heart attack. And I just love this little guy because this is the same look I'm getting from all of you. So understand something. Over 99% of the people in this study were horribly uncooperative. They didn't have a heart attack. Almost no one in the study had a heart attack. Almost no one in the study died. And I've drawn that line at 99% so you can see that the percent of people that did not have a heart attack is over 99%. And yet, there is a 54% reduction in the incidence of heart attacks. So let's see how they did that. Here are the real data. You got almost 18,000 people in this study, and less than 100 overall had a heart attack. So on the left, you're seeing the group that got Crestor. 31 people out of 8,901 had a heart attack, 0.35%. The placebo group, 68 out of 8,901, 0.76% had a heart attack. Less than 1% of the people had a heart attack. So how is it that you can have a 54% reduction? The difference between 0.76 and 0.35 is 0.41. 0.41 is 54% of 0.76. And for those of you who have seen my previous talks in which I made fun of Lipitor, when we're talking about 1% compared to 2%, okay, and I've said, we've got a 36% difference in the others. We are talking about a fraction of a percent. If you do nothing, in fact, if you're a prescriber and your patient comes to you, and you would be like the patients in Jupiter, and the patient asks you, if I do nothing, if I don't take the medication, what's the likelihood I'm going to have a heart attack? The real number you can give to that person is about 0.76% chance of having a heart attack if you do nothing. And that's what I think is important to take from these trials, is how this is called relative risk. This is being able to use the percentages to amplify the appearance of a benefit. And this is how, when you see 54%, it sounds like statins are wonder drugs. But this is so typical of a statin trial that you're really looking at an incredibly small percentage of benefit. And so, in fact, you think about this called number needed to treat. So that 54% can translate to how many people need to be treated with Crestor to stop one person from having one heart attack. And that is 220 people need to be treated to stop one heart attack in one person. Okay. Incredibly weak effects. Imagine, Ivor, if we had a vaccine that week that affected, that had a benefit for only one person out of every 220 people. Or an antibiotic, think about it. Imagine an antibiotic that was effective in only 1 out of 220 people. That's the way you should think about statins. Now, we take this woman who's so happy about the 54% and we give it the real number. Oh, Crestor reduces my risk by 0.41%. And again, this is the trial that is why Crestor was approved by the FDA and is now generating billions of dollars of revenue. It's not the one trial. And so it's very nice that a meta-analysis and review came out last year in JAMA Internal Medicine, in which they reviewed every statin trial, and they looked at absolute risk compared to relative risk. And the arrows are pointing to the absolute risk, and this really tells you the population effect. And so we were talking about mortality, myocardial infarction or stroke. You are down at around overall the 1 to 2%, and the Crestor was primary prevention, but this applies to primary as well as secondary prevention. They looked at all the trials. And even in secondary prevention, you're generally looking at very low absolute risk benefit. So overall, statins are really relatively ineffective, and they don't deserve the title of being a wonder drug. And in fact, the authors concluded that when you look at absolute risk benefit, the benefits are quite modest. Most people in these trials derive no clinical benefit. Now, why is it statins actually have a benefit? Well, the trials have actually shown, and I show this very old review going back 25 years. We have known for decades in fact, that LDL is weakly associated. It's right from this paper. LDL is weakly associated with cardiovascular disease events. They're pointing out non-lipid mechanisms. So statins have multiple effects. They can have anti-inflammatory effects and anticoagulant effects. And that actually explains better why there is a benefit, and it's relatively small, primarily because the statins have these other effects independent of their effects on lipids. So, and I've talked to cardiologists who say, okay, so they have amplified the benefits of statins. And 1% is still better than nothing. But what about the adverse effects? Okay. The adverse effects have been minimized. And again, I have great admiration for Karam and his research, but the reason why he's saying the side effects are minimal, okay, is because they have been minimized. Okay? They have been dismissed. There is not enough information out there about the adverse effects of the statins, which the FDA actually covers at their site. So if we look at the American Heart Association talking about statin safety, one thing they have here, which I find kind of curious, is there are reports of statins producing forgetfulness, impairing memory. And so if I'm on a medication and it's making me forgetful, I don't know how they can say, well, it's not serious. Okay? I think it's pretty serious. If you're having memory problems, in fact, someone here in the audience told me he was on a statin and he had severe memory problems. He went off the statin, it went away. So statins are known to have cognitive deficits. So let's look at one study that looked at this. So here is a study in which you have 75-year-old men and women all go to their physician. They all are diagnosed with dementia, and they're all on statins. And so the first manipulation they did was they took them all off the statin. And a month later, they are no longer diagnosed with dementia. And it's confirmed. Their cholesterol rose, and after a month, they take another test. They're no longer diagnosed with dementia. And the critical manipulation is now they put everyone back on the same statin. And once again, the cognitive impairments return. They are now diagnosed again with dementia. So the question we really want to ask when we're looking at almost half of older people on statins, and we have this epidemic of Alzheimer's disease, the question is, how many of those people diagnosed with Alzheimer's disease on a statin have a fully functional brain that is being impaired by the statins? And that is a question that's not being answered because this study has not been replicated. It's not the kind of thing that gets funded very easily. This is over a decade old, and it's largely being ignored, this study. We published a paper looking at FDA adverse events related to cognition and statins. And what we found was that the structure of the statin relates to whether or not it can cause adverse events. And so the brain has what's called the blood-brain barrier that stops many of the drugs from getting into the brain. So there are statins, because of their structure, are able to get into the brain, and the brain makes its own cholesterol. The brain must make its own cholesterol to be able to produce new cells and make memories. And it's the statins that can get into the brain are the ones that are associated with cognitive impairments. And in that study that showed dementia with statin use, it's the statins that can get into the brain. These three here that are identified are statins that get into the brain and therefore interfere with the brain's machinery to produce cholesterol. Diabetes is a well-established risk factor, but it's been dismissed as a significant effect. This is the only trial I know of in which people explicitly did not have diabetes in the beginning of the study. It's a randomized, controlled, placebo trial in which you have people then either on statin or not on statin, and they are followed over 6 years. So you see in the placebo group, there's spontaneous development of diabetes in 6% of the group, but in the statin group, it's over 11%. So this clearly is consistent with so many other studies that statins do develop, they do cause diabetes in a substantial percentage of people. And that study was done in men. It appears as if women are more sensitive. Here is a study looking at the incidence of diabetes in trials that have a different percentage of women. And the more women in the trial is the greater incidence of diabetes, with the highest incidence in the Women's Health Initiative that had the highest percentage of women, of people developing diabetes. So there was a clear link of statin use to the development of diabetes. I could go on and go over the studies. There are dozens of studies we've included in our recent review in which you have erectile dysfunction, low testosterone, kidney disease, muscle atrophy, and this is all in the peer-reviewed medical literature. Cancer, cataracts, renal failure, liver dysfunction, bone quality. This is all in the peer-reviewed medical literature showing adverse effects of statins. We published a paper recently in which we covered not only the adverse effects of statins, we also made the bold statement to say that if you're on a low-carb diet with good lipids, there is no justification for using statin therapy. And here it is in our summary statement. So what was actually quite convenient, and I don't want to take the wind out of the sails for Dave Feldman, but in a sense, the study has been done, that some of the lean mass hyperresponders is actually studied in the 4S study. So that was a study done decades ago for people with high LDL, but in this reanalysis of that study, which I think is quite convenient, is they looked at people, all of whom had high LDL, but one group was basically unhealthy, having high triglycerides and low HDL, and another group had low triglycerides and high HDL. So they would be like a lean mass hyperresponder. And so again, both groups have extremely high LDL. And you have people either on a statin or not on a statin. And so when you look at the outcomes, really interesting. The people that are unhealthy, high LDL with high triglycerides and low HDL, there's actually a huge benefit of statins. So the people that are unhealthy on a placebo, you have 35% of them had a coronary event. And those people on simvastatin is reduced down to 20%. And that is real. That is an absolute risk reduction. Now let's look at the people that have high LDL, but low triglycerides, high HDL. And so you see under the baseline condition, the people who have the low triglycerides, high HDL, and high HDL and high LDL have significantly lower incidence of events under the baseline condition. And so that just says, first, it's independent of the LDL. Having low triglycerides, high HDL means you are less likely to have an event. But as you can see, on that lower baseline, there is no further benefit of taking the statin. The statin benefited those who were unhealthy. There was another study like this, the PROSPER study. 75-year-old men either had low HDL or high HDL. You find that under the baseline condition, the people with low HDL had a higher incidence of events than those people on the statin. So again, the statin did benefit those who in a sense had insulin resistance. You compare that now to the people with a high HDL and under the baseline conditions have a lower incidence of events, and on that lower baseline there is no further benefit. So one way to look at this is, why is it the statin had a benefit for those with low HDL? And again, I would point to the anti-inflammatory, anticoagulant effects of statins, which can benefit someone that has a high degree of hypercoagulation. But you have a choice. You could be in the left group with the low HDL, be unhealthy, and potentially have the adverse effect of the statin, or you can be in the right group, in which you have the higher HDL and the lower triglycerides, and that would lower the likelihood that you would have an event. And the statin on top of that would have no benefit. And again, these authors have emphasized, in looking at the analysis, LDL was not related to whether or not there was a benefit. The benefit was only in those who had the lowest HDL. Again, sort of an indication that a statin can benefit someone that is really unwell. Someone that has insulin resistance, increased coagulation, the statin potentially can benefit that person, but that person also will have the adverse events of the statins. So to summarize, I recommend, I covered this quite a bit of material and quite quickly. This is in our open access paper that we just published recently. I had the pleasure to work with Ben Bickman, an expert in insulin resistance, and Dr. Paul Mason, a scholar, as well, an expert in lipidology. We're summarizing the benefits versus concerns of low-carb diet. Clearly, the benefits outweigh any concerns. LDL-C, emphasizing, is a useless measure. This fear of cholesterol is unjustified from a purely scientific approach. So first, realize the experts have abandoned LDL-C as a valid marker for coronary heart disease risk. They have focused instead on the particles rather than the total amount of cholesterol in the LDL. But even LDL-P itself is useless, or ApoB, same thing. It's useless because there are different components that all come under the umbrella of LDL-P. So you've got the small as well as the large particles, and the Lp(a) all comes under LDL-P. So again, it is a useless marker. The small, dense LDL is associated with coronary heart disease because it is a part of metabolic syndrome. It is a biomarker to indicate that you're unhealthy, and it is reduced in people on low-carb diet. The benefits of statins have been amplified by using the relative risk. When you look at absolute risk on overall population, the benefits of statins are really rather trivial, and the adverse effects have been minimized or ignored. So finally, the low-carb diet improves all the biomarkers that really matter and that are strongly and likely causally associated with coronary heart disease. And there's just so many people I want to acknowledge, because I have been able to just read hundreds and thousands of papers over the past 15 years. And there are a couple of books that I would recommend. I have chapters in each of these books, and there's so many other chapters by experts in the field. So I think this is potentially a good resource. And I say I'm standing on the shoulders of giants to be able to see farther because of so many other people that I have benefited from. And I'm pretty much almost daily engaged on this topic with and without conflict with various cardiologists and all. And so you're welcome to follow me. My username, I am LDL Skeptic. So I thank you.